that the AC cuts off at 6 because they're usually done with patients at 6, and once we recognize it, we turn the air back up, so it should be cooling off for you guys.
Oh, it's not bad.
Okay. And it's unusual. Usually all of our treatment tables are here, and when we cleared the treatment tables out, I went, oh my gosh, the poor carpet, this carpet. So for those of you that don't know, Dynamic Physical Therapy opened in 2000. It was myself and my husband Steve Sierra, and we opened in this location in August of 2000. We treated our first patient in November of 2000, and so we've been here for 21 years, and we've done a lot of updates and upgrades to this building. How many of you guys remember this used to be the old Al's Video? Is anybody that old to remember?
Al's Video, yep.
Yeah. The electric panel in there still says comedy, horror, Good news is,
This is the comedy section, so we're good for tonight.
I have a lamp.
we have a new building on the way that I am super excited about. My husband is the planner and the dreamer and all of that, and so that is the rendition of what's coming. And what is it? One
Right
block
down-
down
yeah,
and
right
right
down the
across the
road.
street. So new carpet, new everything. You guys want to come to our grand opening
More parking too.
and more parking.
You said your husband's a PT also?
Yes. Yeah.
When are you expected to open?
August.
Yep, August, September.
It was July.
The
Now it's
contractor
August,
keeps
so we
it.
added September. You know how building goes, right? You never believe their dates and don't hold them to
Rain
it.
delays.
but-
So where is that located?
So it's gonna be about 3 blocks that way on the opposite side of the expressway.
When I'm
In
standing,
West Wego or-
In West Wego, yep.
it's
In
right
West
across
Wego.
from the West Wego post office. I was standing underneath and I said, oh, what a perfect landmark. Everybody should know it. Well, everybody,
You
our
can't
age and
miss
older
it.
should know where the post office is. I don't know, the younger
They always
kids.
hang a left at the post.
Yep.
Well, guys, I think we're good on time to get started, so thank you guys all for coming. Paul and I've been doing this on the North Shore in Covington, which is where I live now, and our family is there, and our clinic is there. After Katrina, we lived in Crown Point, and we're very happy that our clinic was still standing and our house was still standing. We were very blessed, and I know not everybody had that, but having young children and twins, and some of our family had moved, so we took a leap of faith and moved across the lake.
I
And
love across the lake. I know family over there.
yeah, and it's a nice place. We have a clinic there. We have a clinic in Slidell now, which we're happy to say. And like I said, this man, Paul, came along 14 years ago, and he's been doing a great job. I still get feedback back from family members that live over here and people I went to high school with and friends, and they all cheer on Paul and say, man, how do you do that? You have a great crew over there. So thanks, Paul. A little bit about us. Thank you for coming. We'll do our best to hold you to an hour. I'm aware of some of the things that we've promised you guys on the video. Want to give you some good information about the rotator cuff, what it is, what are the nature of some of the problems, the causes, give you guys some helpful hints. One little thing after a workshop that I did 2 months ago, we've been doing these since June of last year. And I did this one night, and I was going around and surveying the room, which we're going to do shortly, just to get to know you guys and a little bit more about what's going on. And in the videos that you guys watched leading up to this was how to sleep properly, right? That's a big thing. A lot of people will say, I can't sleep on my bad shoulder, and as PTs doing evals, we hear some things. This man, the only problem he had been to PT, he had problems with his shoulders, and he sat in the room and he said, I'm just here, I brought my friend, the only problem I have is sleeping. Other than that, it really doesn't bother me. And it kind of cued me. I said, okay, I'll show you the position. 3 days later, I'm going into my eval and I have my clipboard, and I see that it was somebody that had come from a workshop, and it was him. And I said, I thought your only problem was sleeping. He said, Michelle, for the first time in 5 years, I'm not kidding, I slept through the night. I don't know why that works. I don't know. And I was like, okay, but if that was your only problem, what brings you here? And he was like, and then as we went through it, sure enough, he still had some limited motion and some other things. He said, why not just take care of it and get it fixed? And I was like, okay. So hopefully some of you guys have the same response with sleeping, but what I can assure you is following that little piece of advice, you will definitely have some better night's sleep, and we'll go over why. So without further ado, Paul, looks like everybody's here, we're ready to get started. I'll have you go around the room, and if you guys want to maybe, as Paul, anybody that's willing to share a little bit, maybe give us your first name and tell us which shoulder is the problem, and a little bit about like what's the activity that really gets you, and maybe how bad is that pain. And we'll kind of survey some of you guys, and kind of we'll look for some common threads around the room, and then we'll hopefully address some of those things in our talk. Who wants to go first?
You volunteer? Here we go.
All right.
Back row.
My name is Laverne Broussard.
Laverne. I'm gonna stick with first names, y'all, because my spelling is bad and my handwriting is worse.
I am a massage therapist and a certified reflexologist, but
So now we know why you hurt.
I have a torn rotator cuff on both shoulders.
Okay.
And I have problems, it wakes me up out of my sleep.
So
As
sleep
long
is
as I'm
that.
laying there massaging it, it's fine, but
Massage yourself.
yeah, I can't sleep.
So your pain level, if zero's none, this is the scale, we'll use zero is
My
none, 10
pain
is.
level is like a 7,
So it gets up there.
yeah.
All right, well, thank you for
And I
sharing.
sleep on my sides, so. I'm
Whichever
switching
side you're on,
back
it
and
wakes you up.
forth.
Okay,
Yeah.
well, hopefully we'll give you, I'll keep that in mind when we go over sleeping and we'll talk about what to do if both are bothering
I'll go
you.
next. I'll go next. We'll go down the line.
Sure.
My name is Beverly Collins, and I have trouble with my left shoulder because I've already had surgery on the right shoulder. And it was not successful. So now I think I'm like overstressing the left one, and I have a lot of problems lifting, doing things over my head, and sleeping on either side.
Okay, so I won't want to sleep again because we'll kind of get a list and everything that's on you, and
Yeah.
pain level.
The pain level usually, if I'm having trouble with it, runs about 8.
Thank you. And listen, we might not get to everybody in the room because we have an hour, so we'll survey a few and we'll try to get some different activities and things. So who would like to go? Who's next?
I have,
Tell me your first name again.
Christine.
Kristen.
I can just say Chris.
Chris.
I have both the torn, rotator cuff, I have a tear in the rotator cuff and the labrum,
Which side?
left.
Awesome. Okay.
And actually I have a little limited range of motion, like with no going back. But I praise God, I'm able to do everything. I still cut my grass and do everything else, so.
Good.
So I can't complain.
And pain level.
I really don't have a lot of pain
Okay.
all the time. It's minimal.
Minimal. As long as you avoid doing those things that are.
Exactly. If I
Okay.
don't have to stretch my arm back, then
When
I
you
won't
do
have
and
any
it
pain.
bites, how bad does it get?
Oh. Tolerable.
10?
Well, I wouldn't exactly say a 10. Well, enough to make you holler, I guess. I guess an 8 it sounds.
Okay. So 8 means make you holla. Okay. My handwriting, I got it.
I had a surgery on my left shoulder, and now I have a pain on my right, my neck.
Neck.
Neck is hurting so much. Pain level is 9 to 10.
Thanks. Now, all kidding aside, what can I call you for a first name?
You can say Hasu, H-A-S-U.
H-A-S-U. Okay.
That's not a good sign for the shoulder, just fell apart.
Yeah, there you go.
Asu. Okay. And what activity seems to bother you most?
Everything. I
Oh.
cannot do anything.
Okay. Well, that's bad. Got it. Is that my seat?
Yeah, my name is Claire. I had an automobile accident and I broke my collarbone, right collarbone. And then last year I had surgery for carpal tunnel and cubital tunnels in both hands. Now they did an MRI because this one cannot live. It lost its strength and there's pain everywhere. And they found rotator cuff there.
Pain level.
Without ibuprofen,
Uh,
8 to 9.
Good. So some of the activities I'm seeing is sleeping. Everybody kind of commented on that one. The lifting of it or overhead, back, everything. And then that's the other one with the decreased strength. Are there any activities that we didn't talk about yet? Anybody has an activity that bothers them that's unique? Yes, Ms. Perry, what you got?
I'm just starting to experience this, so extensions and rotator movements.
Like outreaching to the
Yeah.
side? What is it that you're doing? Are you twisting valves? Are you?
Well, now I'm testing it in a bunch of ways, dumping my coffee out of the
Okay.
cup.
That's actually a positive sign for a
So-
test. You nailed it.
Yeah, so that, I'm just starting to experience that. It's starting to limit how much exercise I'm able to do.
Exercise, that was a good one.
and stuff like that.
Okay. Left side and pain level, what would you say?
I give it a 4 or 5. for
Okay.
sure.
All right.
And a lot of it is probably arthritis.
Okay. We'll call that OA, our good friend Arthur. And I see you saying you have something uniquely too that's different, that's.
Well, the whole body.
Yeah, welcome to the over 40 club. Okay.
Super 50.
My name's Andrea.
Andrea. Yes, ma'am. Left or right or both?
The left, I had surgery 10 or 15 years ago, and then it's picking up again. Well, I'm a water fitness instructor, so I use it a lot.
Okay. Does it bother you in the water fitness
Oh.
classes? Have you modified what you're doing or?
Yes, see right there?
Okay, so exercise.
Yeah.
And,
I tell
and
my
so now it's
people-
affecting your job.
Yeah, I tell my people, if you could do this, you could do this and do this.
Mm-hmm.
What are you doing here?
Yeah, what are you doing here?
Well, that's because I teach water fitness, and they're teaching it for about 20 years. Anyway,
Pain level, what would you say?
I am on 2 extra strength Tylenol every 8 hours. That's bad. 3 times a day because of everything else, 2 knee replacements and you name it, and the carpal tunnel, and it just goes on and on and on, the fibromyalgia and myofascial pain.
So my joke is that truly everybody's looking for the fountain of youth, right? Everybody's looking for the magic pill. I had a workshop guy come in and he kind of felt disappointed on day 1 after the initial eval. I did some things with him and I kind of went over some of what you can expect. We're going to take some range of motion measures, strength measures, look at a lot of things on that first day to really do a full evaluation, and we'll go into some of what we're going to look at. And after I got through it and I kind of explained what was holding him up and what were some of the key findings and the underlying cause of what was going on, I said, well, with that, let me just do one little thing to try and free some things up and get you some pain relief, maybe some increased motion. And we had success, but he was disappointed and he looked at me and he's like, wait, that's it? Like, you're not just gonna like, and it's like gonna be better? And I said, sir, you've had this for 10 years. My pixie dust is fresh out, my magic wand. So there does come to be some levels of expectation, right? Sometimes you have to put some work in, but I'm very pleased that a lot of our success stories are leaving, reporting 85, 90% improvement. Now they know what to do and their motion's better. And, with a re-eval today, I was explaining how some of you guys are talking about 8 or 9 out of 10 pain. And it's like, oh yeah, it's a 9, that's my 9 right here. Well, after a few visits and some hands-on stuff and teaching you what are the right things to do, I've had patients say, well, it's still an 8, but they're way up here. And I'm like, okay, there's your 8. I mean, look what you've gained. Yes, it's still an 8, but as you continue week by, and you improve degree by degree, that you're chasing that pain out. So anyways, enough on that. Thank you guys for sharing your information, and we'll touch back on this and we'll answer some of those things and we'll address some of that with you guys. Let's look at our workshop stuff here. One of the first things we'll talk about on your question and answer forms is number 1, and I'll give the mic over to Paul for a while, because if you haven't noticed, I can talk a lot. Paul's gonna go over the anatomy and really answer the question of what is the rotator cuff? What does it consist of, the anatomy, how it works, and I'm happy to chime in if you would like me to help.
Yeah, sure. All right, so rotator cuff comprised of 4 different muscles. As you can see, our kind of model here. And some of these names are a little tricky. You don't have to know every name, but we're just going to educate you because that's kind of part of the process. So the one on the top part of your shoulder, right here in the shoulder, is called your supraspinatus, okay?
Now,
Right?
what you guys are filling in on there is not those names, so don't feel like you have to spell that out. Do you guys have your worksheets ready and with you to fill in the blanks? Yeah, so, go ahead, Paul.
Directly underneath that one, infraspinatus. This is the blue one right here. Right directly here. So this is the back side of the shoulder. If I was facing this way, this is the back side of the shoulder. So supraspinatus, infraspinatus. Underneath that one, teres minor. Right here. Coming right here. Now if we turn the shoulder this way as I'm facing you, the other muscle is called your subscapularis. This is on the front side of your shoulder blade, as you can see in this model here. Now all of these muscles do different things with your shoulder, okay? And you can have tears and dysfunctions on each particular muscle, depending on what muscle was torn. Like some docs, if you know how MRIs recently, oh, this tendon is torn, this tendon is torn, this muscle is affected. But they all work together simultaneously to basically provide stability to this joint. Your rotator cuff muscles are not your movers of your joint. They're the stability of your joint. So you can have a really strong deltoid, so that's the bigger muscles on top of the shoulder. But if your rotator cuff muscles are not functioning properly, there's an issue there, then you're not going to be able to that twisting motion, right? So they're rotators, right? So they're twisting your shoulder in and out. And some of the exercises we'll show y'all later will describe those different exercises and different motions. So that's basically the anatomy of the muscles of the shoulder, kind of how they function, how they work. The actual joint itself is a ball and socket joint, okay?
So
you
Paul,
can
I'm gonna interrupt
yeah.
you for 1 second. I'm gonna be the teacher.
There we go.
Number 1A on your worksheet. The rotator cuff is a group of four. Four is
muscles.
your first blank of muscles and joints. Your second blank is that move the shoulder. Okay. Then on to B, Paul nailed the next one. The shoulder is a ball is your first, and socket is your second joint. So ball and socket joint.
Right. So talking about the ball and socket, we got our ball, here's our socket. So what's unique about the shoulder is mobility. Our hip is also a ball and socket joint, but, so my hip can go about that high, right? But look at my shoulder. Look how much mobility that is compared to other joints in the body. So it requires more from a muscle standpoint. If I only had to lift my shoulder this high, which is about how my hip can go, the muscles of the hip don't have to work as hard as the shoulder muscles. Because each muscle, as you go up higher and higher, works a different function. And that's why it's a lot easier for us to do this motion, especially if somebody had a surgery or an injury. Yeah, this isn't too bad, but if you say somebody go all the way up here, it's more difficult. And basically what's happening in that joint is if y'all can kind of see this, as you're rotating up, that ball inside the socket is rotating and it's moving. So as you move forward, as you move back, it's going to rotate and move with inside that socket. And you mentioned obviously you had a rotator cuff and a labrum repair.
I have it presently.
We call that a double doozy
Oh, yeah.
in our
It's a
business. So,
doozy.
and this rotator cuff, obviously this workshop is mostly on the rotator cuff, but the labrum is basically a, kind of go off script a little bit, is kind of a piece of cartilage that does show stability for that joint. So even if your rotator cuff is great, if the cup of that socket is incongruent or not smooth or unstable, it can also cause issues as you're moving around, okay?
Listen, Paul, I've 25 years, right? How long? 25. I'm 25 years. I'm dating myself now. I've been doing shoulder evaluations, and I try to give patients an image of what their body looks like on the inside. And I say, look, your shoulder has lots of mobility. We're very thankful. There's no joint that moves, almost 180 degrees. The trade-off for that, lots of mobility but no stability. It's almost like resting a baseball on a teacup saucer. And you have to have good posture, you have to have muscle balance to have that saucer corrected. I have never in 25 years brought a teacup and a saucer in an eval. But I decided, I brought my teacup, okay? So this is the shoulder joint. Here's your teacup and here's your ball. How hard am I gonna have to work to keep this ball on this teacup saucer right now?
Quite a bit.
Well, I'm gonna have to use both hands and I better be real careful. I'm gonna drop my little favorite teacup saucer. My ball is not gonna stay on. It's gonna slide and it's gonna get sloppy. To Paul's point, the labrum is a little cartilaginous ring that helps wrap around the ball a bit. And Paul, if you could hold this up, because I don't have enough hands. There's this capsule and ligamentous, all these rotator cuff muscles form and attach into this capsule that then holds it. So your rotator cuff's primary function is to keep the ball on the socket so then when it moves up, it rotates properly and stays positioned in the socket. One of the first thing that goes wrong, and there's a little analogy that my husband likes to use, I'll share with you, is the muscles get imbalanced or you might have one of the four torn. And what starts to happen is the ball does this and it butts into the bone above it and it impinges one of the tendons of the rotator cuff. Paul was showing you, using this as the example of the labrum, which is really good. This is what I like to say is more like the hip.
That's more like the hip.
So you have a lot more bony stability. This ball is not really, you don't hear of many dislocated hips. We hear often of dislocated shoulders. So you're a trade-off for stability and mobility. So next time I'll leave you with my teacup and sauce. Okay? But I think isn't that a really good visual?
Yeah.
And then my husband's a fisherman. You know, we grew up Crown Point and whatnot. And I'll steal his analogy and share with y'all. So imagine, and I am not an artist, that's why I was math and science, no art, okay? So, but you guys could imagine, here's gonna be a dock. And here's a boat. I don't know, okay. There's my boat in a dock. If we wanna secure the boat in the dock, you know, we have tropical storms and we're always waiting, and this time of year, thank God, we've been good so far. We would tie our boat up and want it to be very stable, and all of our ropes would have to be secure, so that when the winds blow, no matter which direction, that boat's not moving. Now what happens, most of the time, what happens is, one gets a little slack in it. What's gonna happen with our boat? Wind blows from this direction, the boat's gonna head this way. These might start getting little small fissures in the rope, little small tear. When this one gives way, now the boat is clearly going this way, and one of three things is gonna happen. The boat's gonna get damaged from hitting into the dock. The dock's gonna get damaged from the boat, or both. And that's the analogy that we use in the shoulder with that ball and socket. You gotta keep the ball on the socket, or else you get bumping of one into the other. So, thank you. I'll keep you on point to the worksheet so that you guys get your answers before you go, and then you can fill in the blanks. We're on to C, the
Right.
4 areas that work together.
All right. So 4 areas that work together. Number 1, the answer is going to be the neck. So the neck is obviously very important with the shoulder. Most of you probably have real, well, my neck hurts, my shoulder hurts, my neck hurts. And patients come in all the time, well, it's really not my neck, it's my shoulder. Why? So they're so closely related. All the muscles attached to both the neck and the shoulder, so we're going to work on both. Even if somebody comes in saying it's just my shoulder, just my neck, we're going to work on both because we know because they are so closely related. So that was the neck. Number 2.
Let me use you as the model. Turn around. So you remember we were talking about those ropes, right? He's got a muscle right here from his neck to his shoulder. If that one's tight, if I don't work on that on the neck, can you see how that's going to affect the shoulder blade motion? So how can I dismiss that? To the lady there who mentioned some weakness. As a PT, we have to evaluate, is the neck in good shape? Because there are nerves that come out of there. And if they start to get impinged, that may be causing some of the weakness. It may be more neurological than rotator cuff, and so that's good to know. So sometimes one can cause the other. It's like, what came first, the chicken or the egg? We're trained to look at, check out the neck, check out all, and so we'll check all of that before in your evaluation.
And number 2 is going to be the collarbone, also known as the clavicle. You've heard of that one. Basically, that's very important. Bone relating to the shoulder. Obviously, Michelle mentioned ever heard the word impingement before? If that bone is affected, then you definitely can basically, so this kind of move out some of these tendons. An impingement is when 2 bones are rubbing or hitting each other. That does not feel good, and that can definitely cause rotator cuff issues. So number 2 is collarbone. Number 3 is going to be the shoulder blade. So shoulder blade, has anyone seen, like, oh, you got chicken wing blades? Ever heard of that before? So that's another big sign that that shoulder blade is not functioning correctly. Because all of these muscles, and I kind of use Michelle as a model here, we want that shoulder blade nice and tight against her rib cage, okay? If this thing, everybody's seen myself, and they do like this, or they turn in, turn out, the way this shoulder blade functions is vital to how your rotator cuff, how your shoulder functions, how your neck functions, so it's all related. So shoulder blade was number 3. Number 4 is the rib cage. Very important. Just the proximity of obviously your ribs to your shoulder blade, to your neck. It's all very important in how the whole thing functions. So, I think I got a rib here, a rib there. All right, well, let's look at it. Let's address it. Let's see what we can figure out. Is it a rib issue? Is it a shoulder issue? Is it both? So number 4 is going to be the rib cage.
And it makes me think there's this one patient that I'll never forget, that rarely does an orthopedic surgeon call me and say, Michelle, I need a favor. It's usually the opposite way around. It's usually me calling the orthopedic surgeon and saying, have you injected this patient? Because, things are flared up, and they might need a little help or whatnot. So, had an orthopedic surgeon give me a call, and I don't remember how long ago. He said, Michelle, I need your help. I have a good friend of mine. We were at dinner the other night, and she's really got some major stuff wrong. Something's up with her shoulder. I've injected it. She's not really helping. She's begging me to do surgery. I don't really think it's her shoulder, but she's an active. She was mid-50s at the time, loves to garden, was working out with a trainer, loves to travel, in good shape. He said, but, she's a breast cancer survivor. And she had a radical mastectomy and reconstructive surgery 20 years ago. And then more like 5 years ago, 5 years past this conversation, he said she'd had to have a revision because of some scar tissue and some things not right. He said, Michelle, I really think it's more to do with what's going on with her pecs from that surgery, her pectoral muscles, and some scar tissue. Could you please just take a look, see if there's anything you can help? Because I don't want to do surgery on this lady if she doesn't need surgery, and I really don't think it's her shoulder, because the injections aren't helping. I said, sure, send her over. Name was Miss Jackie, sweet. She came in, and she was down. She hadn't traveled, she'd stopped working. She was just down. Her gardening was horrible and stopped working out. And she explained that she had this horrible radiating pain going down the arm, going into the rib cage, all through the chest, all through the back. She had basically a frozen shoulder. She couldn't move it. And I had two choices. I could have given her a lot of shoulder stretches, and I could have yanked on her, and I could have pushed on her. But I said, Miss Jackie, let me take a look at where it had some radiation, some surgical stuff, just starting to do some of that myofascial release technique. And where I started was in the ribs, where some of that chest and breast and pectoral tissue attached to the ribs started getting her ribs moving. Her pain was decreased almost 50% within 2 weeks.
Wow.
It took us time to get the motion back because it had been quite a while, but I got it. She's back to gardening, back to traveling. She's been to us a number of times, sent friends and family. She is forever grateful. And I think that's what is our passion, is being able to help people get their quality of life back, doing the things that they love.
I know the orthopedics that didn't want to do the surgery.
I applaud him.
Some of them want to.
Absolutely, absolutely. And, sometimes surgery is needed. I had another lady where she came in and she's doing this, and I'm like, oh, that doesn't look good. That was probably a full thickness tear. And I'm not going to be able to restore that. But the flip side of that coin is, and we had a lady in the audience at the last workshop, said she's allergic to narcotic pain meds, so surgery was not an option for her. We do see those patients sometimes, or maybe because of heart health or other reasons, they're not surgical. Doctors won't touch them with a 10-foot pole for surgery. It's not an option. So we work with those guys too and help them to restore function. So that was my success story. What about you, Paul?
Yeah, so the ribs obviously, and some therapists they kind of focus on one thing. Oh, it's your shoulder, but here at Dynamic, we really try to look at the entire patient. And with the shoulder, we don't stop at the ribs. We go down to the core. We go down to your hips. We go down to your knees. There's so much that goes on with that shoulder joint. And sometimes it's not even the same side. It could be the opposite side. So I know we're talking about ribs and different things like that, but sometimes if you treat a patient's left hip and get this stronger, especially athletes, people that are throwing, things like this, when you're throwing like this, guess what? All of your strength is coming from here. So you can do all the shoulder exercise you want, but if we strengthen this person's left hip, it's going to take the stress off of the shoulder, and we don't have to treat the shoulder. We can treat the hip, and the shoulder feels better. So just kind of an example of.
I think it starts with listening.
Yeah.
I think it starts with knowing your patient, knowing and just hearing from you guys. What's the trigger? What's the history in the past look like? What is it that is your activity? And then what is it that you love to do that you're not doing right now? And that I think makes the difference. And not overlooking, some of the other body parts that feed into things. So I'm gonna look back at your. I think I told you guys a little bit about me and how I came to specialize in shoulders. I graduated from our LSU medical school in 1995 and started practicing here, and then we opened Dynamic here in 2000. And I honestly think two things that helped really, I was very intimidated by shoulders, and I think a lot of PTs, and especially our newer grads, are very intimidated by shoulders because there's a lot to it, right? There's a lot of moving parts, and it's kind of like a slippery fish. You gotta know where to start. And a lot of times patients are pretty painful. We had two different orthopedic groups here on the West Bank. And I'll never forget this, when I was young. And One of the surgeons was an excellent surgeon, but had very poor bedside manner. Patients would come in, boy, and, bad doctor, choose my, you know. And my husband would say, you don't have to go on a date with him. You just need him to be a good surgeon. And he was a good surgeon, but man, he would give it to his patients. And I'm not naming any names. I'm not going under that list. So well respected. Probably retired now. I don't know.
Yeah, I think he is.
But I will tell you what, and we would have the conversation, I would say, look, I would send my mother to this surgeon, I would send my brother to this surgeon, and he made my job easy because his patients largely did very well. He was doing awesome surgeries. Then there was the other guy, that his shoulder patient would come in and be like, oh God, because I knew they were gonna be so tight and so scarred down, and I have to get both patients better, equally. And I'd say back in 1995, we weren't doing a lot of hands-on and manual therapy. When I graduated from school, things have evolved a whole lot. Paul's younger than me, so he's better for that. But I had to learn those hands-on skills. I had to learn how to get this joint moving, because if I didn't get this joint moving, they weren't gonna get that last 10 degrees because they would get so scarred down. So I think that really helped me. What would you say helped you like become that interest in that specialist in shoulders?
Yeah, so learning over time, obviously as physical therapists, we're required to take continuing education courses. So over the years, I'll be 14 years at PT coming in August, and just taking those courses, learning about the shoulder, learning from Michelle and Steve who have 20 plus years of experience, talking to doctors, listening to patients. A lot of times you listen to a patient, they're gonna tell you what's gonna get them better. You can take every course in the world, read every book, but sometimes the answer is sitting right in front of you, and it clicks like a light bulb, like, oh my gosh, this is what they needed.
And knowing that with our new grads, we have a mentorship program, and we make them shadow with us and train with us and learn those techniques. And sometimes in a more difficult shoulder case, we'll pair up together and make sure.
Makes sense.
But,
Yeah, well, the book says this, well, guess what?
The patient says
The
this.
patient says this, forget the book, look at the patient, this is what we need to do.
All right, so some of you guys have talked about, how many, show of hands, had MRIs in here? Maybe about a 30. How many have had x-rays? Yeah. How many of you had injections?
I had it all.
Yeah.
Sign me up. Sign me up.
All right, so, I'm gonna do a little study that kind of ties into our conversation here, and I found this study, interesting, telling, happy and sad, okay? So, they did research on a group of patients, and there were 100 patients in each age group. But we'll start with the 50-year-old group of patients. 100 patients, okay, 100 of them, had no shoulder pain. No shoulder pain. They wanted to take this 100 group of patients at 50 years old and say, but how many of them had arthritis, spurs, tears, let me see what else they complained of. Impingement. That's that word where things get pinched. They had 100% no pain. They had a combination of MRI and X-ray looking for spurs, osteoarthritis, rotator cuff tear, and impingement. In that group of 100 patients, those that were 50 years old, what percentage of them do you think had these things show up on their MRI and X-ray, but they had no pain? What percentage?
Probably 100%.
I heard 100, I heard 90. And that's usually what people say because they think I might be trying to trick them. It's actually 80%. 80% of 50-year-olds
No pain.
with no shoulder pain had all of these things. So this one is 80%. So they said, okay, 80%, less than you thought. Let's take it up to the 60-year-olds, right? I think actually that they skipped the 60-year-olds. No,
Oh, yeah,
60.
60-year-olds,
How many
yeah.
60-year-olds had, if 80% of 50-year-olds, how many 60-year-olds with no pain had those things?
Stay the same percentage.
It went up to 90%,
It's
okay?
going up.
And then they skipped the 70 group and they went up to 80-year-old people. How many 80-year-olds had that stuff going on?
99.
99%, okay? I guess there's always that outlier. I don't know who's the 80-year-old or the 1% that didn't have any of that and follow whatever he's doing. Does that perplex you guys a little bit? Do you wonder why? Because I've heard you guys say, I have tears, I have spurs, I have arthritis. How come they had no pain, but their X-rays and MRIs showed this.
Because Vanessa sounds.
They were a lot younger? No, they were 50, 60, and
Depends on where
80.
it's located and what it's pressing.
Probably the
Yeah.
muscle.
So, I think all of your answers are probably just partially correct. The big thing is, our bodies are very elastic and adaptable. And do you remember we said all those other parts that play a role? They probably had just enough adaptation and movement, free space in the neck, free space in the collarbone, free space in the scapula, or their body had adapted to work around that, that they were not getting the pain. Where does the pain come from? The pain comes from the inflammation, right? The things budding and becoming this painful inflammatory cascade. And that's why, that we do things to alter the pain, like ibuprofen, I heard that. The meds, right? Oral meds, injections, topical creams. And those things are needed, warranted, and very helpful sometimes to us.
Right.
Sometimes a shoulder patient comes in and everything you do, it's 10 out of 10, 10 out of 10. You're like, oh my gosh, 10 out of 10. They can't do what they need to do. So that's when I call my doctor friend and says, are they appropriate for an injection? When's the last time they had an injection? They're taking their meds, they're doing the right thing, they have them using ice, everything's going right. Can we please help them out? Because if not, they're not gonna tolerate what we need to do. So it's okay for those things. The downfall is injections, especially repetitively and over time, do break down cartilage and tendon, and repetitively done can make you more at risk for tears, and so that's the downside of it. Most of the times what happens is the doctors will give the injection or give the medication, a dose pack or a steroid to really stomp down that inflammation and that chemical cascade, but they tell the patients, now I need you to go to therapy. And what they're knowing is they want us to do the musculoskeletal evaluation and see what are the causes and the contributing factors, and it's up to us to improve the mechanics, restore the ropes around the boat, if you will, so we can get balance so we're not getting the pinching. Many times patients are like, well, why do I want to go to therapy? My injection worked, I'm better. You're not better. You calm down the inflammation, but what doesn't last is you didn't address the underlying cause.
That's why I always say put a Band-Aid on it.
Well, and like I said, sometimes it's necessary. So this is a point where, Paul, did you want to do the miracle? You want me to do the miracle? Have a little 5-minute miracle.
5-minute miracle?
5-minute miracle.
You can do it.
Okay. So we're gonna demonstrate for you guys maybe, just a little one thing that's worked well in the clinic, some hands-on stuff. And so I'll need a volunteer, so don't participate if you don't wanna volunteer, because I might call you.
I'll always.
Well, but I need to look at your motion first, because I'm looking for, I have a certain technique in mind that I'd like to do that works well, it's quick, it's simple.
I'm always a guinea pig.
But I have to look at your motion
Okay.
to see who's gonna be the right candidate.
That's fine.
Because there's a certain movement pattern I'm looking for that this quick technique will show some improvement. So we're gonna go through some range of motion drills. If you don't wanna volunteer with me, don't participate and I won't pick on you, okay? Here's what we're gonna do. And you help me find the right volunteer, you know?
So
I'm
we
looking.
get up
I'm looking.
No, you guys can sit.
Oh.
Here's what we're gonna do. I want you to just raise both arms as much as you comfortably can. All right? And I'm looking for somebody. All right, I have an idea. Okay, good, and down. Next thing I want you guys to do is all look to your left. Let's check out what's going on the expressway. Okay, good. Will you guys all look to your right? All right, good. All right, take a break. All right. Are you, sir, willing to be my volunteer? Okay, come on in. So I told you guys I was looking for a certain movement pattern. If you would, stand here, and we're gonna show this group what I saw and what I was looking for, okay? So I'll stand here in front of you and you can show them. But don't hurt yourself. I don't wanna make you move so much that you need to sign up tomorrow, okay? All right, so show these guys your overhead motion. Do you guys see a different left to right?
Yeah.
What's your painful side? You can
Kind of
mark
more
that.
to the right.
Yeah, I see that. Okay, good. Now, look to your left. Good. Look to your right. Do you guys see a difference there?
Mm-hmm.
Doesn't get quite as far to the right.
Okay,
One more I'm gonna get you to do for me, because what I'm gonna do with you is I'm gonna look to improve your right range of motion
okay,
or your right rotation.
okay.
What's your pain level like when you raise that right arm?
1 or 2,
When
but,
it's up-
but I'm not a good judge of pain.
When it-
I went through a
when-
bypass on a couple of doors.
When it's up at the top, it's a 1 or a 2, so pain's
Yeah.
not that bad.
No,
Okay,
no.
turn and face that way for me, your back to me.
Okay,
I'm gonna demonstrate for you what I want you to do for this group, and You're gonna reach your left hand up for your shoulder blades. So it kinda gets up there. All right, what about your right hand?
Not quite as high.
I'm noticing a
Not,
pull.
not
Yeah,
quite as high.
Yeah, not quite as high. Okay, so the right side is the bad side. Have a seat here if you would. All right, I'm gonna walk you through what we're gonna do. So on your right side, is that a little tender there?
Yeah, right there, yeah.
A little tender, all right. Here's what we're gonna do. I'm gonna ask you to tilt your right ear to your right shoulder. Like that.
Yeah, me doing it.
And take your head and gently try to push into my left hand. Good. Take a nice breath in, inhale, and exhale. Good. And you can relax your head. Take your ear closer to your shoulder if you can. Push into my hand with your head. Push into my hand here.
Oh.
Good. Nice inhale. And exhale. Good. Not hurting you, am I? Okay. Ear closer to your shoulder if you can. Good. Push up into my hand. Nice big inhale. And exhale. Good. All right. Shake it off.
Okay.
All right. Stand up for me. Oh, that works. Okay. All right. I don't know. See. Okay.
Okay.
I don't know you. I've never met before. I didn't pay you $20 before
No,
this, right? Okay.
no.
All right. Both arms all the way up. How does it feel to you?
Definitely different.
How's it different? You come down. Okay. Turn your head to the right. Turn your head to the left. They look a little more even. Hard to say. Turn your back to the group and let's see. Let's put your left arm first. Reach for that shoulder blade so we can kind of see that difference again. Good. And will you try it with the right? Yeah. All right. Small changes. Now, how long has that shoulder been bothering you?
Hard to say. It's a
Few
while.
months,
A while.
few years?
Yeah, years.
Few years. Okay. Well, thank you so much for
Okay.
being our volunteer.
Okay.
What you noticed was you weren't having a whole lot of pain. What you noticed was how it felt a little different.
Yeah.
A little.
Not quite as tight.
Good. Did you guys see a change? I saw a change. It was minor. I like when it's a big change and everybody's like, wow.
Well, that was the first time.
um,
We'll get there.
That was 3 pushes. Do you guys
Okay.
know what I did? What did I do? I didn't even really touch your shoulder, did I?
No.
He did it.
I did a first rib mobilization. A massage therapist in the back probably knows a first rib mobilization. So I'm gonna go off script for a quick second, then all my girls are gonna be mad at me because we go overtime and then I'll be in trouble. Remember how we said we need to look at the ribs? We need to look at the neck? This is your first rib. So that tender spot I was pushing on, it's always tender. It was your first rib. What I did was a muscle energy technique using his head and neck to free up some of these muscles here. Because do you see this? This is a brachial plexus. We freed up a little of those muscles. These are the nerve bundles that go to that shoulder. All I did was create a little what? Space for things to move. And you didn't pinch quite as much. It didn't catch on you before that ball got in the socket. Now if we made 2 or 3 degrees of change with 3 reps, imagine coming to see Paul twice a week, 3 times a week, multiple reps, and then giving you the right exercises to keep that motion at home, okay? So that's where it's individualized, it's fine-tuned, and this was our non-compliant patient that didn't do their home exercises. This is what happens to you. All right, off script. So let's look at where we are. Paul, do you want to go over number 3, getting back to normal?
Right. All right, so getting back to normal, I think this is on y'all's little worksheet. So the first kind of number, or letter A, is if your shoulder pain is reproducible.
Do you want me to do magic?
Yeah, we can do some magic on the board here. Reproducible. Michelle's gonna spell it out for us.
If it is reproducible, what do we mean by that? Man, every time I do this, every time I do this, every time I do this, you know what to do to reproduce it.
Right.
If it's reproducible, then it's what?
You takers on the next one?
Huh?
Repairable.
Reducible.
Reducible.
So if you can make it hurt, there's a pretty good chance we can not make it hurt.
All right, that's all I got for magic tricks. Sorry.
And then B is in the past 30 days, the worst pain I've had was, y'all can kind of fill in the blank on that one.
Past 30 days, what's your pain level been like?
I had a bit of question mark for that, I don't really know.
Well, up here, Miss Travely, right? Miss Chris, you told me 8. Enough to make you holla, unless that was just today.
30 days, okay. I was going by the date. Okay.
And I had pain when, and circle all that fly.
And then I'll interject Paul,
Yep.
and go over, I have another little graph I like to show y'all that kind of throws myself under the bus being a grad 25 years ago. Back to the statistics and studies and graphs. There's a graph that, I'm embarrassed to talk about because I was probably included in this graph back in 25 years ago in my day. And there was the patients that went to PT. They ended up in 3 groups. There was 25%, they were definitely better with PT. 25%. Okay. There was the other 25%, they were kind of like meh. They were no better, but no worse. Okay? Just didn't really seem to do much. Then there was the other group, the last 50%, they were better. It just didn't last. It wasn't the end all be all do all. It didn't get them where they need to be. That doesn't make me real happy as a PT. You remember when I said 25 years ago we didn't learn a lot of that first rib mobilization? I had to learn that on a continuing education course. Okay, it came later for me. The good news is Paul graduated 14 years ago, and so the graph has changed quite a bit. And I'm happy to say, I now sit on the advisory board at LSU's PT program, and so I interact with their students quite a bit, and we take their students here, and I'm happy to be a part of that program. It makes me feel good to give back. And to see the good job they're doing, because we now look like this, where only 10% don't get better with physical therapy. The rest of the 90% do. And to our point of there are some people that they're gonna come in and they'll go through therapy, and lo and behold, they do end up needing to have some surgery. The surgeons are always thankful when their patients have gone to PT first, because we've freed up motion, we've taught patients normal movement patterns, and the patient has a better understanding of their joints and their anatomy, and they usually do better through surgery as a result. So it's not a total loss of your time, energy, and money for PT. So what do you think makes the biggest difference of these pie graphs? 25 years ago to today, I've kind of alluded to it, but it's hands-on treatment. So while this is very good news, the bad news is not all PTs are the same. And I have been on the other side of sometimes, we have very good PT here on the West Bank, we have very good PT on the North Shore, we have some very good competition, I'm not saying that. But I'm saying that I've had patients that come in, and after I do that first rib move, they're like, what are you doing? They never put their hands on me. They just gave me the sheet of exercises and told me to go do my own thing. Or, wow, that really helped, how come nobody else did that? Or how come nobody else released those muscles between my shoulder blade? They never did massage or soft tissue. And so while I'm happy that we're learning this in school, it's just different because not all PTs are taking the time. Maybe their workplace doesn't allow them the time, they're too booked, or maybe they're just disinterested. I don't know why, but we are very adamant about who we hire, how they're trained, and they treat with us so that we make sure you're getting your hands on, and it's not just, oh, go do your own exercises, because you could do that on your own. And we're all used to YouTubing exercises and trying to do our own thing in the gym, and that's really good. But I hope we've established, and we did provide for you guys some exercises that are the top 3 for rotator cuff. One of them is a postural correction, we'll go into that. So, but that was my spiel on that. So Paul, if you wanna take them back to number 4 on the worksheet.
So the number one, right?
Mm-hmm, yeah.
The number one biggest mistake shoulder pain sufferers make.
What do y'all think it
Anybody got any
is?
guesses?
Ignoring.
Wow,
Yes!
y'all are smart. We got
Yes!
an intelligent crowd tonight.
We didn't even give that one away.
And SBTs, we hear all the time, I thought it was gonna go away. I thought it was gonna go away.
Yeah.
And usually the number one thing where I get people to actually come to us, say, well, what made you come? I couldn't sleep anymore. Sleep always gets patients.
So do you guys, you wanna go over that,
Yeah,
sleep?
so transition
I need a pillow.
into sleeping.
And you were my lady in the back there, my little massage therapist. I'll show you guys with her.
But just a very common thing with patients all the time is, I want them to sleep better. Like Michelle said, the patient the other day was, everything feels great except sleep. As humans, we need sleep, and as we know, we don't get enough sleep, we do not function.
There was one fellow at a workshop, and he said, he came in as an eval. He wasn't a workshop person. And I said, so what brings you in? Why are you here? And he said, my wife. I'm here because of my wife. Okay, tell me more about that. Yeah, she's tired of me sleeping in the recliner. Okay. Well, once he discharged, he was happy and he was back and they were snuggling again. She came in and personally shook my hand, said, thank you for giving my husband back. That was a good story. All right, you want to see how to sleep?
Yes.
All right. You guys can watch here. This is an important one because, this is important for you guys not having surgery, being able to sleep through the night. But it's real important for our post-op patients because they do sleep in a recliner sometimes for a week or two, trying to get them back in the bed. So you said you're normally a side sleeper.
Yeah.
So do you mind laying down for me and lay on your side there? However, get comfy. Show me how you sleep. All right. Now what do you do with this on?
I try to keep it here, cause if I do this,
It hurts
I
because
do
it takes
this,
up space.
So I
It
pop
stretches.
pillows behind me.
Good.
And when I do this, the pillows is there to
Okay,
catch it.
good, good. So go ahead, get in your position. But the problem is, how well does it stay there?
It doesn't.
Okay. So raise that arm up for me. I'm gonna shove that right up under your armpit. How's that? Feels better.
Yeah,
Yeah, what did I do?
just prop it up a little bit.
You know what I did?
Which shoulders, she's got
She's got
You got
both.
both, so we can have.
So you know what's gonna happen? Let me tell you what I did. Let me tell you what I did. The shoulder, when it's down at its side, ball and socket, it's in a closed pack position, we call it. Bone to bone is closest proximity. Not good for blood flow. Closes down, obstructs blood flow
That's
through
why
the
my
night.
hands go numb.
Definitely, can be a part of that. So, what happens at night? What is our body doing? It's trying to heal and repair. Largely we know that happens at nighttime. So now she's in a position she's not getting good blood flow. All I did was propped her out about 30 degrees away from her side. Now that's an open packed position. She's gonna get better blood flow through the night. Her body is not gonna wake her up and say, hey stupid, move, I'm not getting the blood I need. Okay? So pain is not gonna wake her and tell her to move. Unfortunately, what do you guys think is gonna happen to this side? It's gonna wake her up.
Yeah.
So she has the option of either flipping to the other side and flipping it around and just flopping like a fish, which some of us do, or would you roll to your back? All right, so if you were on your back, I would still take this pillow and shove it under her armpit. So midway of the pillow under your armpit, but I'm gonna put it behind her arm, and I'm gonna show you guys on this side. And you wanna make sure it's under the elbow, because when your arm is back like this, like you said, it pulls those muscles on the front and will hurt. That's how you're gonna sleep to protect both shoulders. You might wanna roll under your knees so your back doesn't bark at you, right?
I fell 2 years ago and I hurt my hip too.
So a little pillow under her knees would get rid of that back pain, okay? So that's sleeping position. All right, hop on up.
her neck on that pillow.
We're gonna save the neck for her eval.
Not even when-
Because I see my girls saying, come on, Michelle, you're talking too much. Wrap it up, girl. We promised to keep you here
We
an
got
hour,
5
and
minutes.
we are out time on time.
Are we gonna continue this?
Yes, number, what are we on, 5?
We're number 5.
You wanna take it, Paul?
Yeah, 3 things you can do about your shoulder pain right now. We got 3 choices. A,
Take care of it.
no, ignore it. It's gonna go
One is
away.
ignore
It's
it.
gonna go
You can
away.
Continue to ignore it.
B, we can alter it, what you see all the time. Instead of reaching up this high, we're gonna reach up down here because it doesn't hurt as much.
Or the pain meds.
Or yeah, pain meds. Obviously, nobody wants to take those. C, handle it is the answer.
Like you said, take care of it.
Handle it. Take care of it.
Top 3 common causes of shoulder pain. The neck, B is impingement, pinching if you don't wanna spell it, and poor posture.
Posture. I think posture might be number one.
Do you wanna
In my
do,
opinion.
you wanna take him through the demo real quick, Paul?
What's the demo on the posture?
The demo on the posture is this. You guys raised your shoulders up for me and showed me how high you could go. Do that again for me real quick and see how it feels. Yes, Paul.
Alright, that's one I was gonna give.
So this is the one time, see how that feels? See where your motion is, good, bring them down. This is the one and only time you're allowed to have bad posture in a PT clinic, because your PT will call you out. Slump down as bad as you can. And now try to raise your shoulders.
That hurts.
Yeah, it hurts.
Yeah. Now we're exaggerating it, but what do you think happens when you're sitting at the desk and you get tired? Mandy, what happens? We end up down here.
we're terrible about that.
Okay, so posture. So that row exercise that's in your handout there is to help you pull your shoulder blades back, be good posture, because that changes the teacup and puts you in a better position for motion. All right, good. So Paul, number 7.
Number 7.
What does successful, non-invasive, natural treatment look like?
A. Blank on PT to blank move the shoulder. Hands on PT. Hands on PT to move the shoulder in surrounding joints. That is the key. Michelle mentioned it before, we've had several patients that have been in other PT clinics, not talking bad about them, but we find the key to successful treatment is hands-on treatment. The therapist has to get in there, they have to feel the joint, feel the muscles. The only way to assess it in evaluation is the only way to treat it. We have to get hands-on. Just doing exercises, if you have a very, very minor thing and you're young and you're 18 years old, yeah, do some exercises, you're good. But as we know, as we age, hands-on PT is gonna be the most important thing to get you
Oh, I
going.
would even challenge you on that. I had a young swimmer in here, she was 16 and she was active and she worked out with a trainer and she did her thing. But I think to number B, strengthening exercises to retrain muscle memory. It's very different than just a generic gym YouTube exercise program. What's better is knowing exactly which ones you need to do. Which rope is too tight? Show me how to stretch that. Which one is too weak? Show me how to strengthen that. I just freed up 3 degrees of motion for you. Here's how I want you to maintain that until I see you again, right?
Okay.
It should be very individual, very based on what we're working on after I've evaluated you to see what's going on.
Right.
C,
Pain and inflammation relieving modalities. So we find that's another key with therapy. Not a lot of PT clinics do it. We definitely do it here. So that's examples like ice, electrical stimulation, laser on the North Shore, ultrasound. So besides just exercise, we find it very important to relieving the pain.
oh, even your dry needling.
Yeah, dry needling. Anybody heard of dry needling before? Dry needling, another very effective
Great at
technique.
reducing pain and inflammation.
Great at
Not
reducing
anything
pain.
with crystals in the ear.
Yes, we do vestibular rehab.
So just another example of something that we do a little different here, where we're kind of going above and beyond the little extra mile. Say, you know what? Let's put ice pack on it. Let's get some E-stim on it. Let's try some needling. But definitely, sometimes the 5% little extra effort makes 100% of the difference. In my
So-
Say C is ice?
C is pain and inflammation relieving modalities.
modalities. Things that are gonna calm you down. Because sometimes the exercises might flare it up a little bit. That happens.
And we'll
Oh, it
work
hurts
with
worse
you,
when I
we'll
go to
adjust
PT.
it.
Everybody heard that before, right?
Well, guys, did everybody get their blanks filled in? If not, you can come see us after. Wanna do a pose? Wanna do a pose?
You got it.
All right.
So we leave all this back?
So before we adjourn, thank you guys very, very much for coming. Did we provide you with some information? You
Yeah.
feel a little more knowledgeable about what's going on and how PT might be able to help? I'm always amazed. A lot of times people just don't know what PTs
Right.
do.
I like the
in the
hands-on
public.
idea.
So you guys have 3 choices, right? Everybody in this room, I've made you raise your hands a lot. It wasn't on purpose to flare up your shoulders to sign up, I promise. But how many of you in this room are going to continue to ignore it? Yay, good. Then that means we did our job. How many of you guys are gonna continue to alter it? Well, I'll just keep using my left arm. Or I'll just keep taking the ibuprofen.
Take care of the problem.
All right, how many of you are gonna
Genius,
deal
right?
with it and handle it? Yay, awesome, that's awesome. I mean, personally, professionally, our passion is to see you guys get better, and it's so much better when you guys have been here. You guys come in with the advantage of knowledge, and knowledge is power. You guys are a step ahead of the new eval patients that haven't attended this workshop. So I personally won't get to see you, which makes me sad, but you might be getting some emails and some check-ins. Paul and our other therapists that aren't here tonight, we have, our shoulder experts are plentiful, and I know you're in good hands. So I hope that Paul, or one of his counterparts, gets to see every one of you shoulders in here, and I look forward to seeing success stories and hearing good things. So these girls have been waiting in the looms. There's a couple of things, and Mandy, I'll let you decide. You can tell me how you want to take them. Usually what we do is, they typically have about 300 visits a week on the book, Monday to Friday. But knowing when we have a workshop, Mandy holds some spots, okay? So whether you wanna just come in and do a quick screen with a therapist, no ties, no insurance, nothing, free. You can meet with a therapist and discuss your own issues a little bit more one-on-one than in a group setting. Get a little more
Yeah, more for
answers.
those individual questions.
If you know, hey, I know I need to see you, well, you can schedule an evaluation. You don't have to schedule anything. You can just keep in touch with us from afar, whatever, but I hope you guys come in and take care of it. I would usually say those that have the higher pain levels, or you feel like your situation is a little more urgent, do you wanna take them one by one? Each of you guys could take one and just, now the rest of you that aren't gonna go with those ladies, stay back with Paul and I. We'll talk with you one-on-one, answer any questions that we didn't get to answer here with you. But the other thing I really would like to have back from you are those checkout sheets. There's a little information that if you do have to run, because your kid's at soccer practice or something silly and you forgot them, you can run out the door and they can get in touch with you at a later date if you need to run. But we would like any feedback on how you felt tonight went, and any ways that we can make it better for a future one. Thank you so much for coming. We have a pool on the North Shore, and we are trying really hard to get a pool on the West Bank. Yes, I understand. Our doctors, I'm gonna tell you, the pool is best for 2 patient groups. 2 groups. It's the very, very painful group that cannot tolerate therapy in general, like you try to do anything and they just flare up out the wazoo. Chronic pain, some of my fibromyalgia patients, people that have failed in physical therapy and the doctors don't know what else to do. Water is amazing, getting rid of gravity, movement. They say motion is lotion. Movement, getting blood flow. So for those that are really bad off, we even have some quadriplegic patients, some kids with special needs that get in the pool that just fight gravity and they can't move real well. That's the lowest and the hardest. The other group it's really good for are our athletes. Those guys that just had a surgery or knee surgery, ankle surgery, but we don't want them to lose their conditioning and they can't walk, they can't put weight on, they can't be on a bike. I can suspend them in the pool and have them run laps, do jumping jacks, swim. Yeah. I typically don't treat shoulders. I have been on the North Shore since 2007. I stay there, but Paul is my right hand here on the West Bank. And I only do pelvic health now. I don't do orthopedics anymore. There was a long time ago when I came with Yes, yes, Sarah Schmidt. She went to Andrews in Texas. But I know your face. I've either seen you as a patient or you're related to somebody I know. Because I know that face. Yeah, but Dr. Katz? Let me tell you that. Yeah, he used to be Dr. Katz are on my ass now. That's a different number.
Never gave it back.
Yeah, we bonded after the treatment. It's okay. I'll be ready for that. We'll see you.